along those same lines, Frank, from a real practical approach, it seems like you oncologists always start stuff really high, apologize, and back down. Endocrinologists start low, and we raise the insulin. We start low, and we raise the thyroid hormone pill. Help me understand this. Should we really be starting at the max dose of any of these drugs, or should we start lower? How do we think about that?
Right. So I, personally look at the fact that I think if you, especially with lenvatinib, you're going for a response, that if someone comes in with pretty extensive disease or disease that I want to try to attain the best response, I'll start with the highest dose. And like I mentioned earlier, I'll follow them back weekly to see. And it doesn't mean we're not going to reduce the dose. If we have to, there's intolerability, we can't control the, hypertension despite, various antihypertensive agents, et cetera. But I believe that to attain the best chance for response, you really have to start with the highest dose. And then you adjust, accordingly. The same thing with sorafenib. I think the same thing. If you start low and try to work your way up, we've done that. But I don't personally, in my own anecdotal experience, see the benefit. And Marcia, I think we've talked about this
well,
too.
I think we definitely have seen in anecdotal experiences that there does seem to be a dose-response relationship. So if you want to get the results that we're seeing in the clinical trials, you have to follow the way the clinical trial was done. There are opportunities often to stop, and then as Frank keeps alluding to, when he goes back to the same dose initially, because sometimes it could clear up and you don't necessarily have to decrease the dose. And so if you can try that once or twice, if it's not working, then you can decrease the dose. But let's be aware of the fact that on the trials, the average dose of sorafenib was 650. So about half of the patients had needed at least one dose reduction. Right. In my experience, if you go to 2 dose reductions, you're more likely to start having escape. So if somebody had a response and you go down to 400 milligrams a day, you're more likely to have creeping up of the disease. So we do everything we can. And again, that is harder for an oncologist because you have to really work to keep those side effects down. You have to put time into it. You have to put nursing support and resources. It's always easy just to decrease the dose. Sure, you can get rid of the side effects, but you'll also get rid of the benefit. It's also important to note that in the SELECT study, the average dose went down to about 16. And so the starting dose was 24. So that's 2 to 3 doses down. And now actually there are additional studies going forward to decide whether or not you really, in that situation, because 40% of patients had grade 3, 4, which is very high. Mostly it was grade 3, but that was quite a large increase in blood pressure and did quite often lead to headaches and symptoms from that. I think that it's important for us to know, do we really need to? But that will be answered actually in the context of a clinical trial. And outside of data saying it works just as well, we also always start at the
We're
full
uniformly
dose.
going for the high dose and trying to help tolerate
Yeah, I'm just going to play devil's advocate. Maybe just only because I come from the endocrine background, as you pointed out. But, if we know majority of the patients are not going to tolerate the 24 milligrams for long, and in the SELECT trial, the vast majority were dose reduced very early on. There were a few that tolerated the full dose, but it's early on. I think, one could see both sides. I'm one to prefer to start at a higher dose as well, but there are those patients who, given their comorbidities and their disease burden, you do worry that they're not going to tolerate it. And so we have started plenty of patients at 10 and 14 milligrams and have had very nice responses. So I think, just like Marcia said, that I think we don't know.
Well,
and
some of those patients may not have even been eligible for the trial.
For the trial,
absolutely. So when you're outside of patients who would have been on the trial, I think you have to customize it for sure.
Absolutely.
But if the patient would have been otherwise eligible for a trial, I don't think you have to be aware that when you go off script, you may not get the results, and it may not matter if it's not symptomatic and stuff. Right. But I think it's important. I'm a purist when it comes to that. Unless I have a reason, again, a guideline, but with a reason, I will do something different.
I think that's how I do it too. It's like if I want to try to attain that response, I try to go for the gusto with the biggest dose. But I agree with you. If you look at somebody and there really isn't a response needed per se, that I need to shrink something down, I may start at 10 or 14 milligrams.
Let me ask you my